Atrioventricular septal defect, AVSD, also known as atrioventricular canal defect, is a complex congenital heart defect that involves abnormalities in the structure of the heart's atrial and ventricular septa, the walls separating the heart's chambers, and its atrioventricular valves, the valves between the heart's upper and lower chambers. Anatomy of AVSD. AVSD results from a failure of the common atrioventricular junction to properly separate during heart development, leading to a defect in the septum between the atria, atrial septal defect, ASD, a defect in the septum between the ventricles, ventricular septal defect, VSD, a single common atrioventricular valve instead of two distinct valves, mitral and tricuspid valves, which can be malformed and may not close properly, leading to valve regurgitation. Types of AVSD. 1. Partial AVSD involves an ASD and a cleft in the left atrioventricular valve, allowing shunting of blood between the atria but typically not between the ventricles. 2. Complete AVSD involves both ASD and VSD with a common atrioventricular valve affecting blood flow between all four heart chambers. Clinical presentation: heart murmurs, often detected shortly after birth due to abnormal blood flow through the heart. Signs of heart failure, including rapid breathing, difficulty feeding, failure to thrive, and fatigue during physical activity. Cyanosis, a bluish discoloration of the skin and mucous membranes due to low oxygen levels, more common in severe cases. Diagnosis: echocardiography, the primary diagnostic tool providing detailed images of the heart structure and function. Electrocardiogram, ECG, may show signs of chamber enlargement and abnormal heart rhythms. Chest X-ray can reveal an enlarged heart and increased lung vascular markings due to increased blood flow to the lungs. Treatment. The treatment of AVSD typically involves surgical intervention to correct the defects, usually performed in infancy or early childhood to prevent complications such as pulmonary hypertension, heart failure, and growth retardation. Surgical repair involves closing the septal defects with patches and reconstructing the atrioventricular valves to ensure they function properly. In cases of complete AVSD, the common atrioventricular valve is divided into two separate valves. Prognosis. With timely and successful surgical repair, most children with AVSD can lead active lives, although they may require lifelong cardiological follow-up to monitor for potential complications such as arrhythmias, valve dysfunction, or residual shunts. High yield points. AVSD is a congenital heart defect involving defects in the septa and atrioventricular valves. It presents with signs of heart failure, heart murmurs, and potentially cyanosis. Echocardiography is key for diagnosis. Surgical repair is the definitive treatment, with good outcomes when performed early. Long-term cardiological follow-up is essential to monitor for complications. Clinical case: atrioventricular septal defect, AVSD. Patient information: age 4 months old, sex female, medical history, no significant prenatal history, full-term delivery with normal birth weight, no family history of congenital heart disease. Presenting complaint: the patient is brought to the pediatric clinic by her parents due to concerns about poor feeding, slow weight gain, and increased breathing effort, especially during feeds. History of present illness: the patient has been increasingly fussy over the past month, with noticeable sweating and rapid breathing during breastfeeding. The parents report that she seems to tire quickly during feeds and often falls asleep before finishing. They also note that she has not been gaining weight as expected for her age. Physical examination: general, mildly underweight for age, mild tachypnea at rest. Vital signs: heart rate 160 BPM, respiratory rate 50 breaths min, oxygen saturation 95% on room air. Cardiovascular: a loud, harsh holosystolic murmur best heard at the left sternal border, a diastolic murmur also noted. Respiratory: clear lung fields, no wheezing or crackles. Other exams: no cyanosis, clubbing, or significant peripheral edema. Diagnostic workup: chest X-ray, enlarged cardiac silhouette with increased pulmonary vascular markings. Electrocardiogram ECG, evidence of biatrial enlargement. Echocardiography reveals a large inlet ventricular septal defect, VSD, a primum atrial septal defect, ASD, and a common atrioventricular valve with moderate regurgitation. The diagnosis of complete AVSD is confirmed. Assessment: a 4-month-old female with failure to thrive, increased work of breathing, and heart murmurs. Diagnostic findings are consistent with complete AVSD, leading to volume overload, increased pulmonary blood flow, and signs of early heart failure. Management plan: 1. Medical management. Initiate diuretic therapy, e.g. furosemide, to manage symptoms of heart failure and improve feeding tolerance. Nutritional support to address failure to thrive. 2. Cardiology referral. Urgent referral to a pediatric cardiologist for further evaluation and surgical planning. Surgical consultation. Discuss the timing and approach for surgical repair of the AVSD to prevent the development of pulmonary hypertension and to improve cardiac function. Surgery typically involves patch closure of the ASD and VSD, along with repair or reconstruction of the atrioventricular valves. Follow-up. Regular follow-up appointments to monitor growth, development, heart failure symptoms, and readiness for surgery. Postoperative follow-up will focus on recovery, monitoring for complications, and assessing the need for further interventions. Discussion points. Early recognition and intervention are crucial in managing AVSD to prevent irreversible pulmonary vascular disease and to ensure optimal growth and development. The complexity of AVSD requires a multidisciplinary approach, including pediatric cardiologists, cardiothoracic surgeons, and specialized nursing care. Long-term follow-up is essential to monitor for residual defects, valve function, and potential arrhythmias.